Well, hello everyone, and welcome to the Thursday, October 1, 2020 session in our series of public lectures and Stanford University seminars on digital transformation in traditional and new industries in Asia. I'm very excited that today we're not looking at big for-profit making companies. What we're looking at is nonprofit sector and what kind of an impact the nonprofit sector is having on healthcare in India. We have a wonderful panel to talk with us today. Before I introduce them, I do want to say thank you to all of the 21 member companies that are supporting the U.S. Asia Technology Management Center. This is how we have the funds to put on programs like this. And so I do want to welcome everyone to our session. If you have a question during the session, please write it in the chat window, and I will relay it to our panelists when we get through with their prepared remarks. After the formal session concludes at 5:50 p.m. local time here at Stanford, we will continue with an informal, completely optional networking session for those who stay until 6:15 or 6:30. So we'll stop at 5:50. But for now, everything you say is recorded, and we will be posting this to YouTube in a few days. So I'm delighted that to discuss this topic about nonprofits in Indian healthcare today, we have two entrepreneurs and a person who is a mentor to entrepreneurs. We also have one of the persons who is not only an entrepreneur, but a social impact investor. So first I'm going to call on Dr. Priyanjali Datta, who is the founder and CEO of Aaroogya. And Dr. Datta is an alum of ESSEC, a public health-focused central government hospital. She's also been recognized as a top 50 global healthcare leader. She is one of the top 10 women achievers in 2018 as designated by Outlook and Hero Honda. She's a Rex Karamveer Chakra awardee in 2019, and her documentary film received the Best Documentary Film 2018 at the 4th International Film Festival. After Pri talks about her activities, we're going to turn over to Ms. Rekha Pai-Kamath. And Rekha is really more of an angel investor and managing director of a family foundation right now, managing director of the Kamath Family Foundation. But she's led new business development at a number of major Silicon Valley firms, including most recently Juniper Networks. She also serves on the board of Fast Forward, an accelerator for tech nonprofits that's based in San Francisco, and Intelehealth, a tech nonprofit that's building intelligent technologies for last mile health, which was really my first thinking of Rekha. So Rekha has been on the Alumni Council for Tech Women. She has spoken for the U.S. Department of State in several countries. Yeah. So Mr. Ravi Rao is the head of strategy and operations for Cisco India's research and development site, a role in which he drives several site-wide strategic initiatives. He has extensive experience side of Cisco India, where he has been a mentor to Pri. So I'm going to ask Dr. Datta, I'm going to ask Pri to start our session off today.
Good evening and good morning, everyone. I'm so pleased and glad to be here today on this panel and have a great discussion ahead and to interact with all of you. Thank you, Professor Dr. Datta and Kimberly, to have me here with a wonderful panel with Rekha and Ravi today. I would like to start with a small video. Cancer may affect 1/3 of Indians by 2030, and a large majority of cases will be from disadvantaged backgrounds. 7 out of 10 people die due to late detection. Poor awareness and a lack of health infrastructure is a major cause of late detection of cancer today. Whole families are pushed into a poverty trap, with medical expenses soaring up by 5x. This narrative is repeated across developing nations. We at Aaroogya Foundation want to change this. We work on early cancer diagnosis in the most vulnerable group of patients, women, who suffer from 3 out of 5 top occurring cancers. Using artificial intelligence assisted tech intervention and on-ground support by our fellows, we empower frontline healthcare workers like Asha AMM in India and mid-level healthcare workers in Africa to screen women for cancer. We have screened 51,000 plus women, leading to early detection of cancer in 2,900 of them. Based on this screening, high-risk women are connected to nearby hospitals, while women with low risk are advised on ways to prevent cancer. A helpline in multiple Indian and international languages also provides more information about cancer prevention and care. A continuous process of screening will result in skilled healthcare workers, a better aware society, and help governments map the population for habits and disease burden. We at Aaroogya are an international team of doctors, health professionals, anthropologists, and technologists working to help frontline healthcare workers easily screen people for common cancers. Early screening can stop cancer before it eliminates another life. To begin with, in 2016, while I was in my school and studying in dental surgery in a government college, I started this nascent organization, a public health organization called Aaroogya Foundation. Aaroogya in Sanskrit language means free of diseases. I started by self-examination teaching by going door to door in Meghalaya, where I come from. It's a society where women predominantly take care of the family and earn a living. And it is a tobacco growing rich area. So I started there. And over time, I realized that the problem is so gigantic and massive that alone with my going door to door will hardly solve a drop of its problem in this vast ocean. In 2017, I was really lucky enough to have my co-founder on board with me, Dr. Dhruv Kakkar, who joined us, established maxillofacial prosthetic surgeon, and also leaving a government job and joining a nonprofit organization was a big move and shift for him. He believes that we can reach, millions of women with the help of scalable model. And I would like to tell you how big the problem is to begin with. Nearly 600 women are dying every day in India due to cancer. Just last year, we lost one of our friend and patient, Lakshmi, and we don't want to let another Lakshmi go. So we took a pledge together that we want to reach 50 million women around the world to give them and enable them with the access of early detection of cancer, which can save their life if timely screened. Dr. Dhruv and I had in-depth conversation of the problem, and we consulted a lot of people to measure the depth of it before going on ground. And we realized that even with the physical ability and money to create physical infrastructure of healthcare delivery for a country like India, which is almost a continent, it will take another 90 or plus years. And that is not very feasible or sustainable to begin with. And hence, we started testing and trying our models. We began with collaborating with many organizations who were creating smart tools that could be easily mobilized and could be used for screening of cancer in remote places. We collaborated with Government of India in one of the projects in Bihar, in a district called Buxar, which is one of the lowest human development index holding district in India. And we screened only 10,000 women in 6 months and realized that even partnerships was not enough to set out this mission, and we started new and fresh in 2019 by realizing that technology is the way. To give you a perspective on how big the problem can become, in February 2020, WHO released a study saying that 10%, that is 130 million Indians, may be encountering cancer in their lifetime by 2030. And this population is as big as more than 3 times the population of California itself. And the top 3 cancers were breast, cervical, and oral that was released, which logically says that women, especially from disadvantaged backgrounds, are at the highest risk of encountering and developing these cancers. In India, 2,000 women are detected with cancer every day. Now, that is not enough. The problem is much bigger and deeper. The problem lies with families who spend almost all their assets in order to try and give it a shot to save their loved ones. But 7 out of 10 women in India lose their lives before 5 years of treatment due to getting detected in late stages of the disease. Now, the expenses are quite high for an average Indian family in late stages, as high as more than $25,000. Also, the end result being not being able to save their loved one mostly. Versus in another situation where if enough decentralization of healthcare can occur and community screening is enabled in a very easy way and scalable way, the early detection of this disease will cost them somewhere around $5,000 to $8,000, which is much lesser, significantly lesser than the treatment in late stages. Families are pushed into poverty trap because of these soaring high medical expenses. Okay, 1 second. Now, India is standing at a critical point where 2% of its GDP is lost due to untimely detection of chronic diseases in people. This is not exclusive to India. This situation mimics across nations where public health system is weak. And we all are witnessing that amidst the pandemic, and we can face the reality right now. COVID is aggravating the problem on the ground excessively. There is mistrust against the healthcare workers because they encounter patients every day. The healthcare system is overwhelmed right now, and there is not enough skilled healthcare workers across. Also, there is lack of PPE. So the little progress that we made over some decades is also getting compromised. Now, what do we intend to do, not just as an organization, but to enable systemic change by collaboration with similar organizations and start a wave of decentralization of healthcare? Aaroogya is a social enterprise trying to create globally scalable products and model to enable community level early detection of cancer screening in women and mobilize them for timely action. We call it My Healthline solution of products. We are trying to build highly robust, scalable, and secure tech-enabled tools in the form of mobile applications, web portal, data dashboards, and helpline information system in multiple languages for semi-skilled community-level workers so that they can initiate and conduct primary screening of these women and quickly mobilize them towards the right path. We follow a 3-pronged approach. We call it 3T approach: technology, training, and tracking. We are trying to build a robust artificial intelligence assisted technology which at the front end is very easy to use for a semi-skilled worker, and it is in the form of questionnaire. But at the back end, our doctors and technologists and researchers are working extensively to perfect the decision-making model and make it as scalable and as perfect as possible. Our doctors are always overseeing it so that we make no mistake. Training of local authority, training of our partners, and training of fellows to further train their community healthcare workers is something that we also hold hand with our partners to do. We track the women after getting screened. The high risk patients are mobilized to nearby hospital for further detection, and the low and moderate risk patients are screened again biannually and annually respectively. We don't leave them after one-time screening. We try to track them. We have a multi-channel approach so that easily people can reach out to us, and we cause a wave where the local authority can be easily tracking on their data dashboards about the progress that is happening and the change that is getting created in the process. We also try to do this so that the semi-skilled worker who are already there as an existing wiring in all healthcare pyramids at the base of it, they get upskilled and digitally unified as a task force. This will also help government map population for disease burden and create eventually a predictive analysis and better decision making process. We try to inculcate every feature which makes it easily scalable, to make it work at low bandwidth, make it as customizable as possible as per the requirement of a particular place. And we try to partner with local healthcare workers, the grassroots organizations, authorities, and healthcare systems in that area so that we can create a holistic ecosystem. Our approach is to not just restrict ourselves as one brand, but to create this solution for everyone to adopt. We offer full stack product, limited, and also options to integrate it in existing systems of other organizations like telemedicine or general lab and electronic health record platforms. We are aligned with the United Nations Sustainable Development Goals, primarily with number 3, that is for good health and well-being. And we also try to contribute our little bit towards partnerships for the goals and foster gender equality, reduce inequalities, and create innovation and intellectual infrastructure. And we all hope to see an ideal world where poverty is alleviated. Our larger vision and ultimate aim is quite ambitious. We want to create unique cancer ID and risk profile for everyone, and that may act as a highway for other solutions to build over it. For example, government policies, other solutions by private and public partners, and also strategies to make the situation better, just like Uber over Google Maps. You can see the ecosystem of Aaroogya. We have team, we have fellows on ground who are coming from various backgrounds like masters in social work, masters in public health, masters in business administration, and aiming to become and learn social entrepreneurship, and they get on-ground experience with also some strategic experience with our team. We work with local administration very closely, local partners very closely, and the frontline healthcare workers. They are the main users. We have progressed so far by screening 51,000 women and diagnosing 2,900 of them early, and launching in Africa with the help of a grant by Millennium Alliance, which is a consortium of USAID, UK, Facebook, Marico, and FICCI. We, during COVID, created a consortium with Intelehealth and leading a consortium of 23 social and technology organizations, and we have reached 200,000 plus people in 50 places. This is our team, young leaders who are working with us, general support, some media coverage. And I would like to end by saying that we have to choose now what is luxury for us. And a Wall Street Journal said that perfume is packaged better than social impact. So time is ticking. Let's join together to move the needle. Thank you.
Pri, thank you very much for your comments. It really is, a challenging scale and a serious problem that you're attacking. I'd like to go ahead before we ask any questions and ask if Ms. Rekha Pai-Kamath would give us your prepared remarks at this point.
So thank you, Dr. Datta. I really enjoyed listening to all the impact that you guys are doing at the Aaroogya Foundation. And I actually didn't know about it, but I've heard about it from Intelehealth a lot. So I'm really excited to be here with Ravi also. Dr. Asha, thanks for bringing us together in this critical discussion about healthcare access in India, especially considering the numbers we have with COVID. So the situation everywhere is bad, especially in the US and India. So I think this is a really critical discussion, and I'm honored to be part of it. A little bit about me. I'm a partner and board member at Silicon Valley Social Venture Fund. We make grants and impact investments. Together, we practice something called venture philanthropy at SV2. We can talk more about it. If anybody has any questions, connect to me offline. But I'm also an angel investor on the side. As Dr. Asha said, I manage my family foundation, but I'm also on the board of Fast Forward, which is a tech nonprofit accelerator here in the Silicon Valley. I'm right here next to Stanford in Los Altos, actually. Through Fast Forward, I met Intelehealth because Intelehealth is our 2016 alumni. And last year I got on the board. So I'm really excited. That's why I guess I've been invited here. So I'm excited to talk about Intelehealth. Anything about Intelehealth right now is like really exciting because of the progress they've made and, we've made and stuff like that. Every day I keep getting really fun news. My background is in technology companies doing product management, product development. My last job was at Juniper Networks, managing new business incubation efforts. Before that, all the tech companies in the Valley. I'm here because my heart overruled my mind. So, let me talk about kind of a story. Last Jan, I got the privilege of visiting our pilot in Odisha, which is why I joined the board. When I went with the team had the goal of interviewing the beneficiaries, like the villagers that we had the pilot with. And so we took a 2.5-hour flight from Mumbai to Bhubaneswar. So just to give you a sense of how remote this place is. First of all, we went to Bhubaneswar, 2.5 hours from Mumbai. Bhubaneswar is a tier 2 city. It's a capital of a state called Odisha. And Odisha is a place where 1/3 of the population makes less than $1 a day. So it's below 1/3 of the population is below the poverty line. So after landing in Bhubaneswar, we drove about 4.5 hours to a remote coal mining town called Talcher. Because Talcher was the furthest place with a decent motel before we could travel to the villages. This was the base camp before heading out to the villages. So over the last Talcher was, once you drive towards Talcher, you can already feel the air full of dust and soot from the coal mine. So there was you could see there was a lot of dust pollution and soot. It's called the city of Black Diamond because of a reason. It has the biggest coal mine, second biggest coal mine in India. Over the next 3 days, we would drive 1 or 2 hours over dirt roads to the surrounding tribal villages in the Angul district and interview the health workers. We would talk to patients coming to informal makeshift clinics. We would talk to community health workers traveling on bicycles from village to village, right? This NGO we were partnering, it's called Ekal Vidyalay. And we were partnering with them, and they had rural childcare centers at like these rural villages. And the classroom would also double as a rural teleclinic where one of our frontline health workers attends to the patient. You can see that. So I was so inspired. That's me and Karishma, one of the Intelehealth team. But the other two are these young, vibrant, cheerful frontline health workers who took great pride in their work. And I was left with a sense of how critical the need of healthcare access was in rural and tribal villages in India, right? When we talk about healthcare access, we talk about access in terms of geographic access or financial affordability. Those are the two metrics we think. But many times, public clinics that are funded by the government may not have doctors incentivized to actually be there when the patients get there, right? Or there's a lack of education and awareness of health issues as well as what services are available. Or there's social stigma and cultural barriers that can complicate an already existing healthcare access problem, because neglected groups like elderly and women are always deprioritized in the family because of cultural issues, right? Poor access to comprehensive primary healthcare could also mean that early diagnosis and prevention is completely overlooked. So something that could have been treated long ago, as Dr. Datta just pointed out, early screening makes such a big difference before health problems become bigger, intractable, and cost so much more for the whole GDP and for the economy. And so poor access also means that despite government-funded financing schemes, that people don't even know how to avail of them. So there are so many facets of access issues, and Intelehealth, I believe, helps empower community health workers to not only be effective healthcare providers, but also be promoters of positive health behavior and agents for change. And I'll let you know how. Because at Intelehealth, we solve this problem by enabling the local person, the community and frontline health worker, to deliver high quality, and this I mean by evidence-based, high quality, comprehensive primary health care. Intelehealth works with grassroots organizations like NGOs, local governments, and hospitals to implement digital health and telemedicine programs for the last mile. So they're not only a software provider, they also provide training and implementation support to set up the programs. And they also take ownership and accountability and constantly work with partners to achieve the impact outcomes. That's why I think it really has the value that it can, the impact value that we've been able to achieve. The Ayu app, right? The Intelehealth app, it's a mobile expert system. It's powered by medical research done at Johns Hopkins University. It's an expert system with knowledge engine with of care protocols with more than 70 primary care conditions. So the community health worker uses this digital assistant. It's trained in using the digital assistant. He or she is usually a local person, and they're trained to conduct screening of common conditions, collect medical history, conduct a physical exam, and all this is guided by the Intelehealth app. The tech then enables the community health worker to ask you the same exact questions that a doctor would ask, so that the right data and the right information is collected. And this way, the community health worker is actually able to deliver the healthcare, basic healthcare. They're able to advise the patient. And if needed, then they connect the patient with a qualified doctor over telemedicine. So in this way, data and medical evidence drives the actual diagnosis. That is what I feel really differentiate a telemedicine platform such as Intelehealth with other teleconsultation platforms, where the doctor can actually make an accurate diagnosis. And it's sort of like the doctor's expertise is delivered to the last mile, right? So let's look at the healthcare outcomes from Odisha. I'm just talking about Odisha because that's one of my favorite projects from Intelehealth. Of the 50,000 people that Intelehealth worked with from 80 different villages, just demographically, 70% of them are tribal and socially disadvantaged. So 70% are scheduled caste and scheduled tribe. That is a caste that, it's complex, but in the caste system, they're the lowest rung. They're like absolutely down at the bottom. 99% of them are below the poverty line. 60% of them no formal education. Most of them are farmers and daily wage laborers. But I was floored by the impact, right? 6.5 hours of average time saved per patient. It's usually a whole day's worth of work. And the money saved, which is $10.50, was enough for a child's education and supplies for 2 months. Think about it, that's big deal for a laborer who's earning less than $1 a day, right? This is about and of course, we have healthcare outcomes that show that if you had medical adherence, then you had very good healthcare outcomes. And so we are working on the medical compliance piece, but that's a standing problem in healthcare. So Intelehealth's work in Odisha we've been working on it from 2017. But the NGO we were partnering with has seen the value, has renewed the contracts, and is expanding the scale of this work across many more states in India. But we also work in the Philippines, Haiti, and Syria. But the COVID pandemic came and completely changed everything, right? COVID has disrupted the delivery of regular healthcare in rural areas so much. And it has also highlighted the importance of the role that Intelehealth, something like an Intelehealth, a telemedicine platform, can play in the delivery of routine healthcare services, right? So Government of India has issued actually guidelines that encourage remote healthcare for delivery of essential health services. They passed the guidelines, and that became huge for us at Intelehealth. So we are now working with state governments and district. We are starting with the Morbi district in Gujarat to set up telemedicine projects for Ayushman Bharat program, which is the state-run healthcare system. In addition, for COVID, Intelehealth is part of a large partnership, and that's why I was hoping that Dr. Datta, we can talk more about it, and Ravi, we can talk more about it, but I'm really excited about this partnership and collaboration effort with 32 organizations in India, both NGOs and the corporate industry, to create a pandemic task force, right? Where Intelehealth works to create awareness using educational training material for healthcare workers and staff of NGOs so that they learn how to be safe with COVID. As we know, India has thousands of NGOs doing amazing work, right? NGOs like Pratham, Gunj, and all of the list that you see are doing great work in the field of education, whether it's life skilling for adolescent girls, or humanitarian aid, or vaccine distribution. You hear about the great work that all these amazing NGOs are doing. But these NGOs are mostly large grassroots organizations. They have networks of volunteers and staff who are in the local community, who are embedded in the local community, and who can be agents of change. The good thing is, actually, they currently run active programs, even now, despite COVID, just because of the sheer need of the moment. And the problem is they have to act fast to respond to their communities, right? But they are very resource constrained. They don't have funding, and they don't have access the healthcare services that they can provide to their communities. So just like here in the US, just as we have so much fake news and misinformation and confusion about COVID, about how to keep safe, we have vulnerable populations in rural India that have the same misconceptions. And sometimes it's even worse. Like Neha was telling me, you can rub peanut oil on your belly button to be safe. I mean, this is the kind of misconception that comes in about COVID. So in order to educate and raise awareness for COVID safety, Intelehealth partners with NGOs by training their staff, workers, and volunteers for COVID safety using the train the trainer model. So we want a scalable, sustainable model. So we do it by a train the trainer model. And in this way, NGOs become a distribution network for Intelehealth. So the distribution network is all of these NGOs that you see on the platform. But then we also have corporate tech partners who help in product development and technology with app and website development and hosting, right? Those are Infosys, Wipro, and Portal Frame. And we also have content partners like Noura Health who help create the videos, VideoWiki, which help translate it into local languages. And videos have even been made accessible with sign language with this, I think it's called hi.org, right? Intelehealth also, the impact you see in just 3 months, and I give kudos to Neha, to people like Dr. Priyanjali Datta, and to Ravi in supporting them. But Intelehealth used the IntelliSafe app and resources to deliver infection prevention and control training using the train the trainer model with 33 NGOs as delivery partners, and they were able to train more than 1,400 NGO staff master trainers. And these master trainers then across 22 states then trained the 6,300 field staff, who then distributed the healthy messages to 41,000 families and community. So this kind of scale of impact was only possible. It shows to the power of collaboration, right? It shows to the power of collaboration with NGOs that such a huge impact has been able to be achieved in such a short time. So just a minute about why I'm an investor in this model. Dr. Datta asked me to talk about it. I love the Intelehealth model so much because it has all the signs of a sustainable model that can scale so well. The solution and the intervention meets the beneficiaries where they are because of its low bandwidth tech and low bandwidth tech. It's actually no bandwidth. It works offline. The local language support, and it leverages local community healthcare workers who are trusted members of the community to deliver patient-centered, high-quality, dignified healthcare. So in the for-profit terminology, this is called a good product market fit. I also like the go-to-market strategy, which we call in the for-profit world. What I mean is Intelehealth currently partners with grassroots organizations, local NGOs who have already given us recurring contracts. We're starting to work with state and local governments who are seeing the value in strengthening and leveraging existing health infrastructure and resources. So I look at it as an investment towards large-scale impact because Intelehealth uses technology to scale efficiently because of their innovative platform by reducing cost. So I think that's all I have. I mean, I can talk about these are our funders, but I'll stop right now and we'll go towards, we'll answer any questions towards.
Okay, Rekha, thank you very much. Those are great comments. We're getting some great questions coming in. I'd like to encourage everyone to write your questions in the chat window, and I'll be picking them up after all of our speakers have finished their prepared remarks. First, though, I'd like to ask Ravi Rao, who is with Cisco Systems R&D in India, to talk about the perspective from Cisco's standpoint, the NPO sector, and what Cisco is doing to interact with them.
Thank you so much, Dr. Datta, for that introduction, and thank you to Dr. Priyanjali Datta and Rekha as well. I'm thrilled to be part of this panel discussion today, and privileged to be here. So as Dr. Datta mentioned, my name is Ravishankar Rao, Ravi for short, and I run a function called Site Strategy and Operations for the Cisco engineering team here in India, a group of about 6,000 employees. In the past, I've worked extensively with healthcare customers and partners across the world. And also, I think as has been mentioned, have worked extensively with both Intelehealth as well as with Aaroogya Foundation. Before I sort of get into the meat of the presentation, one of the things that sort of struck me during COVID-19 is how it hasn't spared even the ubiquitous stethoscope. I think there have been several doctors, I think across the world, who have probably not touched their stethoscopes in the last, 3 or 4 months. And in some sense, I think, it probably will have to go through a completely digital avatar, in the next sort of few years, right? So it was just very interesting to me that something as humble as a stethoscope was not, spared. So I think with that said, I just wanted to, I think, provide some perspective about Cisco and, the corporate social responsibility work that we're involved with. So I think most of you, in the Bay Area, probably know Cisco. It's a $50 billion, approximately $50 billion company, networking company. But what is not necessarily as well known is that we're really very focused on corporate social responsibility and giving back to the community. So we rank, for example, as one of the most sustainable companies in America. We do work across, multiple fronts, whether it be focused on, renewable energy, or whether it's even running the world's longest and largest CSR education program, what we call NetAcad. From an Indian standpoint, there are really 3 focus areas that we look at: education, economic empowerment, and critical human needs. So Rekha Pai-Kamath talked about some of the organizations like Pratham and Gunj and organizations like that. So we do work extensively with those organizations in India. We do have a goal in India to impact 50,000 lives by 2025. And one of the reasons why I got, I think, involved in the healthcare nonprofit space is because of a partnership that Cisco launched with an incubator called the Nudge Center for Social Innovation. And both Intelehealth and Aaroogya are actually alumni, of that program. So essentially, we pick 8 or 10 nonprofits, on a 6-monthly basis, where we provide mentorship on a whole, range of fronts to really get them maybe to the next level. So with that said, one of the sort of things that I see, right, when I look at, founders or nonprofits in general, is that generally the entry point is someone who has very strong technical depth, in their domain and vertical. That tends to be the primary entry point. But what we have seen is that, and where Cisco, for example, sort of understood in many other technology companies, is that many of these organizations are very new to technology and new to software. So there is a role that technology companies can play in helping them build out their software platforms. The second thing also is that from a go-to-market, I think Rekha used that word. It's more a very business sort of terminology, but it's more about how you take that to market, and it applies to both for-profit as well as non-profit companies. And I think there's we do definitely see gaps there as well. And of course, process is extremely important to sort of optimize the level of time, the amount of time that healthcare workers or the organization spends. So in a nutshell, I think if you have if you have these 4 dimensions covered in some sense in your team, it may not guarantee success at the outgo, but it's at least the first step towards building a scalable or a replicable one. So, I think previous speakers touched upon, sort of the notion of scale, but I think from an Indian context, scale takes on an entirely different meaning. These are just 4 examples that I sort of picked out just to sort of demonstrate that. So Aravind Eye Hospitals does about 450,000 eye surgeries per year. That's about 1,200 per day. Akshaya Patra actually is the world's largest midday meal scheme. 1.8 million students across something like 20,000 schools. Gunj is a disaster and humanitarian NGO that works on providing clothing to a large number of underprivileged students and people across multiple states. They work across 22 states in India. And the Honeybee Network is a brainchild of a person by the name of Professor Anil Kumar Gupta, who has sort of traveled rural India for the last, I think, 30 or 40 years documenting innovation. So there's actually a compendium of rural innovations that now he's compiled over those many years. But the reality, in some sense, is that given that complexity, I think the NPOs or the NGOs in India fulfill yawning gaps and critical gaps in terms of healthcare delivery or even delivery of critical services. So much so that it is sort of referred to as the third sector. The challenge that you see from this is that give or take, there are about 3.3 million NGOs. So there's no dearth of NGOs or NPOs in the country. But the challenge is that it's very, very heavily fragmented. And if you actually look at the numbers, and if you are aware of perhaps the number of beds or doctors per 1,000 people, you'll actually see that the number of NPOs or NGOs are actually higher than that on a per 1,000 people basis. So the reality is that because of the fragmentation, sometimes there's a dilution of effort across some of these NGOs. So, how do you really get to very, very positive outcomes at a country level? That's something that I will probably explore a little bit later. But I think, needless to say, I think scale is, it's really never enough, right? Just considering India's scale. So I think Rekha talked about Odisha and the work there. So that's the state actually in yellow that you see here. But I like to use the total fertility rate of major Indian states to, I think, maybe demonstrate a point that India is actually probably 2 countries, right? So there's one part of India which is probably closer to Germany or Sweden in terms of total fertility rate. There is another part of India which is probably closer to states in Northern Africa and Central Africa. So the reality is that you probably have to develop two fundamentally different strategies in order to sort of go after both of these populations, right? And it's when you look at also the digital readiness map of India, and if you sort of overlay that with the TFR map, you'll actually find that there's probably a 70-80% correlation in terms of what you see, right? So the states that probably are in red or in orange are the ones that are probably the most digitally, or they lack the most digitally. And also, I think when we think about philanthropic spending, in the country, being a major source of funds for, nonprofits, if I were to just contrast two states, Maharashtra and Jharkhand, and this is from Bain, basically Maharashtra is, capital city is Mumbai, that has probably the maximum number of millionaires and billionaires in the country. And what you actually see is that it gets a disproportionate, perhaps, allocation of philanthropic investment, but perhaps due to its proximity. Whereas if you look at a state like Jharkhand, where the poverty rate is much higher, you actually see a very, very minuscule percentage of philanthropic funding, going to that state. And the inference in some sense is that success begets success. So money chases, I think, successful models. And in reality of this is that, maybe the vulnerable populations in many of these states are sort of being left behind. So you also need to figure out how to reallocate some of that funding to create, better outcomes. So I wanted to take a slightly different view around just the technological perspective around, how that can sort of bridge the gap with respect to problems in healthcare in India. So this is a fairly busy slide, but what I wanted to sort of talk about, or at least when I think about the problem, it's about looking at the issue, what is the primary issue that you're trying to solve, and the outcome that you're trying to look at. On the basis of that, you have to sort of identify, in some ways, the technology intervention. So given the level of scale in India, you almost have to sort of design that from the ground up when you develop your technology or software. So that could be an open source model, a microservices model, or perhaps even a container model, something that can easily scale. Secondly, when you look at poor infrastructure that is there in the country, there is a critical need to reduce the burden on existing systems. So, solutions like what Intelehealth or Aaroogya bring to the table around telehealth and so on, sort of reduce that burden on that primary healthcare system. I think home care is probably the next sort of evolution to that. And you can sort of maybe move a lot of maybe even people at-risk patients, can be taken care of by at the home. The third thing is, in all of this, I think security is, critical, right, to ensure. And it's ironic that to increase the level of trust in a system, you have to almost move to a zero trust architecture where, you don't trust anyone, any actor, any player, any person, right? So the system is really designed to sort of check that at every given level, right, in order to ensure that data is secure. And then I think when you look at the lack of time and access, I think you have to also look at reducing the friction in the process. So that may mean interoperating with multiple third-party systems. That may mean making your app, your application so easy to use that it sort of reduces that change management. I think given the number of languages that India has, vernacular support is also critical. The last point that I want to mention here is that there is a lack of data in the country, and I've kind of sort of steered away from talking about AI or ML. I talk about more analytics in general, but I think that's another huge area that technology companies can help, where technology companies can help nonprofits and improve the outcomes as such. So I think with that context, how does maybe a nonprofit cross the proverbial chasm, right? And I think there are really two parts to this. One is the way I've sort of maybe explained this is what is changing from an Indian context, and what needs to change, right? And I think it's a no-brainer that governmental support is absolutely critical. NPOs and NGOs really fulfill critical gaps in that government infrastructure and delivery mechanism. But what I wanted to just touch upon here is from a what is changing standpoint. The government of India is sort of looking at multiple ways of maybe trying to increase the level of access through technological intervention. One of maybe the maybe quote unquote successful ways is Swachh Bharat or Clean India, where they built about 100+ million toilets since 2014. So it's really the first step towards public sanitation and health and sanitation in general. The second thing is that there is a whole suite of applications which are being built out, which is sort of codenamed the India Stack. And the most sort of famous application of which is called UPI, which is essentially a financial protocol that allows money transfer from any bank account to any other bank account. It's being explored by multiple countries. Something like 1.8 billion transactions just in the month of September. So that's built on Aadhaar, which is biometrics for 1.2 billion people, again, over the last 5 to 6 years. And I think Dr. Priya talked about an interesting point, which is that many people are pushed into the poverty trap. And one of the reasons for that is lack of documentation. And by having a biometric mechanism, you actually you don't need any physical documentation to sort of prove your identity, right? So it's essentially an identity management system, right, to say the least. The next evolution of that is the healthcare stack, which is where they're going to provide maybe a health ID to different citizens. And the reason for that is, given the disparate healthcare systems that exist in the country between state healthcare, central healthcare, and so on, it probably will act as an agency or an intermediary to sort of help interoperate both of these different systems. Dr. Rekha Kamath talked about Ayushman Bharat, which is providing insurance coverage for thousands of underprivileged citizens in the country. And the reason for that is out-of-pocket spending is, I think, something like 60 to 70% of total expenditure. And there are a number of grants as well that are being sort of offered. And I think COVID has also demonstrated that, right, in terms of the number of applications. Another interesting thing is that philanthropy has also increased quite considerably from 2010 to 2018. But I think we have to sort of look at maybe moving that or trying to optimize that across the spread of a country as complex as India. And from an industry standpoint, what I would say is that the government again has mandated a 2% net income to be allocated towards CSR projects for companies beyond a certain threshold in revenue. And so a lot of work that Cisco does and many other technology companies do in India is using that money, right, to sort of, deliver that to organizations like Intelehealth and Aaroogya for them to, take their organizations in some sense to the next level. And there's also a huge sort of broadband infrastructure that's being built out in the country. And I think a large number of, and it's probably a mechanism by which if you get yourselves maybe attached to that broadband expansion, you can also scale quite considerably. The last point I want to make on this slide is that what I have seen maybe over the last 15, 20 years is that, there is a significant amount of risk taking among, the youth in terms of starting companies. And I think that's very, very heartening to see in terms of not necessarily accepting the status quo, but really actively trying to sort of change it. So I think what needs to change, or at least from a continued focus standpoint, again, I think it's a no-brainer that the government of India probably needs to increase their healthcare spending as a percentage of GDP. The primary healthcare system is obviously very critical, to increasing, health outcomes. But I think more importantly, regulatory standards and data protection, I think, are two areas that I think need to be strengthened. So there is a data protection bill which is currently in the parliament sort of being debated, but I think that will go a long way in some ways, at least in alleviating some of the privacy concerns and security concerns. And I think from an NPO or NGO standpoint, female literacy and empowerment, in my mind, probably is one of the areas in which, by focusing on that, I think history or literature has shown how it sort of influences a country's GDP positively upwards. Wastewater and sanitation, again, has a very strong correlation to health outcomes. And I think there's a critical need, and again, technology in some sense can help in optimizing skill and capacity building. And I think monitoring and evaluation as well is super critical in terms of what is being funded and the outcomes that come out of that. So in some ways, I think that, again, right, cooperation between the government and NPOs and NGOs, where feasible, I think will help. And the other thing is, given the lack of data, data dashboards perhaps can, sort of go back or be sent back to the government. So it's almost a push and pull mechanism, to sort of influence, both sides. So some of the things that perhaps I think, for nonprofits to think about, as I've sort of worked with nonprofits, I think one of the things, if you're running a nonprofit and if you're part of the audience, one question is, are you really comfortable with your level of scale and impact? And I think one point there is not just about the level of scale or impact that you're able to generate, but it's more about whether you can generate that sustainably, right? And I think to the previous point around, the fragmentation around nonprofits, I think alliances or mergers could be an option. So I think, as Dr. Priya mentioned and Rekha mentioned, there is a COVID alliance, a task force where I think 20 or 30 organizations came together, collaborated together to sort of really, deliver sort of lasting change, right? Mergers could potentially be an option. I think it is something that is probably more prevalent in the US, but not so much in India. And then the other thing is, when you look at sort of those 4 dimensions, do you really have the right level of leadership, right? And what I mean by that is, from a technology perspective, I think some of the nonprofits, as you move in the technology space, would probably help you to look at maybe a CTO, right? To help you think about, your overall tech strategy. I think the other piece also is that it's not necessarily the most successful or the most successful companies or the most successful organizations may not have the most thought-provoking or groundbreaking idea. I think it's a question of being able to connect, collaborate, integrate, standardize, and replicate. So it's a bit of a mouthful, but in my mind, that's kind of how you sort of may have to think about, the model and how you sort of, run your organization. I think the other thing is that for-profit companies as well do have, some good practices. And while there is a lot to be said about that, I think there are certain things that you could probably look at. The other piece also is, given the level of focus, and given the level of the number of people that you have, generally short-staffed, think about how you want to insource versus outsource, what you want to sort of keep as core, and then what you want to sort of give away, right, and leverage the external sort of ecosystem. The last point here is that I think, in my mind, technology is just an enabler. And I think what I would just recommend is, don't chase fads for the sake of, so don't get caught up with many words like AI, ML, or even things like blockchain. I think what has to happen is, it has to make sense with respect to the problem that you're trying to solve. Because at the end of the day, we're fundamentally a network of people. We're not a network of, robots. And I think the last thing, and this is my last slide, is that, in my mind, in order to sort of make this really go round and deliver awesome outcomes, is there are 2 ingredients to this, right? Trust and transparency. And I think if you sort of have both of those ingredients, probably move quite well. But if any one of those are in imbalance, it will lead to, suboptimal outcomes. So I think with that said, that's really all I had. And maybe back to you, Dr. Dasha, for any questions.
Okay, Ravi, thank you very much. We do have some questions from the audience, but I think I'd like to start out, because you have 3 basic sectors in the economy. You've got the government, you've got for-profit, and you've got nonprofits. I'll leave the academics out because they have kind of a different function, and they tend to get funded from the government and industry anyway. But I'm really curious why for-profit companies are not taking on more of this opportunity to really reach the last mile in India. Is it just not a business proposition that can be done in a for-profit manner? Let me ask kind of all of our panelists for that. Why do you think that you have to do this as a nonprofit instead of as a for-profit? Pri, you go first.
Thank
Hello,
you.
are you muted? Okay.
Thank you, Richard, for that question. That's a critical question which cannot be definitely answered as per me. The reason that I can talk from the perspective of Aaroogya, the reason why we consciously started this organization as a not-for-profit is because the end customer, the end consumer, do not have the capacity as of now to pay for screening, and they are the people who are directly getting impacted. Having said that, the people who are working with our end customers, that is government authorities with the frontline healthcare workers, private organizations, and many companies who work to build solutions over insights of data from population to help real time, may become potential customers who can pay. So we are also evolving from being absolutely a nascent organization to a sustainable social enterprise. So that's our journey, and we are still discovering.
Okay, thank you. Rekha, what do you think? Why was Intelehealth better as a nonprofit?
So I have a thank you, Dr. Datta, for leading us on, for giving us the perspective from a social entrepreneur perspective. But I mean, fundamentally, my the philosophy here is that if there is communities in that have so low disposable income that markets cannot be viable there, so private industry will not focus on markets where there is no affordability to pay for products and services that you bring to them. So in Intelehealth's case too, if you go to rural and tribal villagers who are making less than $1 a day and ask them to pay even a little bit, it just adds to the poverty trap. And we so there is a case for doing nonprofit solutions towards communities that are socially disadvantaged, economically disadvantaged rather, that have no disposable income, that they're making lower than the minimum. So in India, there's so many infrastructure problems, right? Like water, sanitation. A person in a rural village does not have the power to even access those basic infrastructure problems. So healthcare access has been deprioritized for a reason, and there's just not enough of a market there.
So I'm guessing that to follow that up, really the government itself could not put this into the budget and do some sort of Scandinavian solution where basically on the basis of taxes, the government's providing all the services. For a place like India, that wouldn't work, right?
Well, government has its own budgetary, and I'll ask Ravi because he's in India right now, but I'm thinking the government has a lot of asks for its budget, and there's a lot of corruption, and the systemic access problems are because the money is not reaching the beneficiaries even in the healthcare access system. It's the budget is not being used efficiently is what I would think, right?
Okay.
Yeah.
Ravi, I want to change that question a little bit for you, though.
Sure.
I was going to ask more about the government role in sort of encouraging more coordination among all of these NPOs, or at least helping technology standards. I noticed that Dr. Datta mentioned that there are guidelines that startups are supposed to follow, but does the government play a constructive role in trying to keep all of these nonprofits from just being a chaos?
Yeah, so it's a very, I think, interesting question, right? So I think from a government perspective, I think governments, for the most part of the world, are fairly messy, right? I mean, they have a lot of, major objectives that they want to sort of accomplish. But the reality is that if you don't sort of provide the level of spending that is required, sometimes, there's pilferage, there's corruption, and so on and so forth, right? So I think the government probably has its, the right intentions, but how those intentions sort of translate on the ground, I think always is sort of maybe subject to interpretation. So I think, at a minimum, at least some of the interventions that I've sort of talked about in terms of maybe the India stack or the healthcare stack or things like Ayushman Bharat sort of indicates that, they're trying to sort of change that. But the reality, I think, at least from an Indian standpoint, is they have to increase the percentage of spending on the basis of GDP, number one. That I think is an absolute minimum. I think the second thing also is that governments in India especially, probably are slower, maybe to respond to some things, right, or at least money not reaching the right places. So what I would say is that it's probably a push and pull, right? So whether it's the industry or whether it's the nonprofit, there is a push and pull, right? You have to create a certain pressure mechanism in order for governmental agencies, to act. So I would say that COVID-19 is probably the, a really interesting sort of kick to the system to say you actually have to start looking at some of these things. So a lot of the stuff around telemedicine, telehealth, or even the healthcare stack is sort of, I think, getting more and more importance as a result of pandemics like COVID. So yeah, I mean, it's a difficult question, but I think there is definitely an effort now to streamline that. I think the only other point that I would mention is that to your earlier point that multinational companies now in India, as I said, have to provide 2% of their net income beyond a certain threshold towards helping the community, and so the government also mandates a whole bunch of compliance requirements to make that happen. So in a sense, to unlock a source of capital.
And that would flow into CSR. That would flow into the nonprofit sector, not into government taxes.
Correct. That's
okay.
Right.
I want to start my next question really with a comment. Of the several million non-government organizations in India, I would guess that probably the huge majority are what I would call organizations that do social services. You mentioned grassroots organizations. They're local, they're trying to help provide an immediate need, but they're not really aiming at system change. When you get into social entrepreneurship, you're really looking at how the system changes. And both of our nonprofits in this session are using technologies really as a key to kind of get some system changes happening. And I'd like to ask both Dr. Datta and Rekha if you're seeing differences in the way local healthcare workers interact with the people that they are screening, that they're trying to help as a result of these technologies. Rekha, why don't you go first?
Sure. This is a great question because I'm seeing through testimonials of, the villagers on the ground, system change occurs when, the biggest indicator of system change is when a culture changes, right? So, when you see patients who feel more confident of their place in society, who have more agency in taking care of their own health, when you have women who in their families, are more of, take more of the sort of leadership or more agency in how they speak about their health and the health of people around them, then there's system change. So the picture that you saw with me with those young vibrant healthcare workers, that is the epitome for me. Is like when they have a smartphone in their hands and they're taking care of the health of the villagers around them, they have so much confidence of being agents of change. They can become leaders, and that's from the local ground up we see that change coming on. So they become, they become more confident of looking for services that are available. They are now getting to know about using of technology. They may get educated. They may encourage other people around them to get more educated and aware just because of one intervention of healthcare intervention. They just become more agents of change. So that's how I'm seeing the systems change.
Okay, the people become the agents of change. Pri, what do you think about this?
Richard, in India and recently Africa, where we have started exploring the daily work of frontline healthcare worker, It's pretty much same cross-border because it is at the base of the pyramid and requires basic healthcare delivery. These are mostly women, which is an amazing thing to observe and explore. And these women at the first place become community healthcare worker because they have the passion and the skill to have leadership to bring a positive change in their community. And they aspire to do so in their best of capability. Having said that, when they get upskilled and a sense of more respect to do more than the defined work that they were doing before technology or smartphone came into being, they feel more uplifted, and that drives them better to push the entire healthcare pyramid skill wise a little above, and that makes the cycle of better delivery start. So I would say that healthcare workers at the base of the pyramid are the most important key people to focus on and strengthen the entire delivery.
You're reaching them though remotely, right? With the healthcare app,
Yes.
My Healthcare app.
Yeah, My Healthline smartphone
My
application.
Healthline, I'm sorry, yeah.
Dr. Dasha, I want to add one more aspect of the system change. I think tech companies and anything that gives data and more transparency in the system has the advantage of being able to leverage different aspects of the ecosystem so that there's more system change. So in the Intelehealth case, the moment you have like health data about a village, I mean, the villagers can get more empowered in that knowledge, and the NGOs can get more empowered in the knowledge. So the more data you have of health outcomes, of in general health predictors, I think data and analytics and constantly measuring that over time also results in systems change, right?
Right. Ravi,
I
one
just
last
wanted to add
question.
maybe, yeah,
Go ahead, Ravi.
I just wanted to add a comment to that, right? So I think
Sure.
the data dashboards is like very, very critical, right? Because governments also probably don't have access to, a lot of data at the grassroots level. And I think there's another element to this also, is that the government also funds, several $1 million, let's say, in a particular area or a community. But then how is that fund utilized as such, right? So I do know of nonprofits that are actually reporting on fund utilization at a very local level, at a village level, and that information then goes back and sort of gets updated on, let's say, a governmental dashboard. So I think there is a push and pull, as I mentioned, and I think you almost have to create a groundswell to make yourself noticed. Right?
I think that's a good point. One last question for you, Ravi. We have a worldwide audience here today. What would you recommend to people outside India who are interested in getting involved with some sort of nonprofit activity in India?
Yeah, so I think,
Supporting
so I think definitely. I think for one, what I would say is whenever COVID-19 passes, do visit India, because I think as a country, it is quite complex, and I think it's probably an experience for those of you who have come here. So I think it probably will sort of help you understand the sort of the nuances of dealing with a country like India. But I think, having said that, there are definitely a number of ways in which you can sort of contribute. I think, of course, the no-brainer answer to that is funding for sure. But then, more importantly, what I would say is that through organizations like Aaroogya or Intelehealth, there's a lot of work that's already taking place. So what I would say is reach out, to those organizations and figure out how, in a sense, you can help. And if you're actually looking to create a nonprofit or start a nonprofit, what I would say is do have a base in India, because that's critical. It won't work otherwise, right? You need to be here to sort of make lasting change.
Thank you. For those of you who can stay, we're going to continue some more informal conversation after we close the formal part of the class. Next week, I'd like to say that we have a venture capital fund who's doing a data-driven approach to portfolio item identification and valuation. So I'm looking forward to that discussion as well. Thanks everyone for attending. Thanks very much to our great panel. Really learned a lot, got a lot from the session today, and we hope to see you all again next week.